Good morning, good afternoon. I'm Robert Caudell, Training Director for the University of Louisville Department of Psychiatry Residency Program. I'm introducing Dr. Syed Abbas, who's going to speak to us this morning about management of psychiatric disorders, patients with stroke and traumatic brain injury. Thank you, Dr. Abbas.
All right, thank you very much, Dr. Caudell. As he mentioned, we're going to talk about management of neuropsychiatric complications of stroke and TBI. This was a journal article presented in the Indian Journal of Psychiatry in March of 2022. Going into outpatient, I thought this was an appropriate topic to discuss. It briefly covers, a lot of the general common neuropsychiatric complaints you'll see in elderly patients following a stroke. And so we will begin. So neuropsychiatric complications are pretty common after stroke and TBI. Globally, just some data, there's 16 million annual new strokes, of which 5.7 million people die, and of those 5 millions are left with long-term disabilities. The prevalence of general neuropsychiatric complaints after stroke are about 30%, depending on which meta-analysis you look at, and are determined to be kind of major predictors of poor outcome in those patients. And one thing to kind of keep in mind is a combination of disabilities related to stroke and disabilities from the neuropsychiatric complications, particularly psychosis, is one of the most serious and detrimental outcomes. Often neuropsychiatric complaints, unless they're like frank delusions or psychosis, can be overshadowed by the physical complications of CVAs. There's not too much research to inform on evidence-based practices in management of post-stroke, so a lot of the recommendation criteria is taken from management of other psychiatric disorders. I do want to start off on a lighter note here. This is a rebus puzzle that my wife introduced me to a book, Tale of the Dueling Neurosurgeons. It's like a history of the human brain and stories of like trauma, madness, recovery. And so these are kind of fun to do. They're all neurological terms. This one, I believe, says neuron circuit. So our purpose of this review is to kind of go over the clinical practice guidelines based on the categories of evidence for the following neuropsychiatric complaints: depression, psychosis, anxiety, PTSD, mania, emotional lability, fatigue, apathy, and personality changes. So we'll review, based on the available literature, the recommendations for treatment of those conditions in people following stroke. And these are the categories of evidence where the recommendations are drawn from. Category 4 would be the strongest, which is evidence from opinions and or clinical experience of respected authorities or expert committee reports. And strength of recommendations, strongest being the standard of care, or even D, which is directly based on category 4 evidence. So we'll start with post-stroke depression. It's the most commonly reported. Depending on which time frame you're looking at, the approximate prevalence is 25%, and it's naturally associated with worse functional outcomes. It can occur, as I mentioned, anytime between 1 to 18 months following stroke. There's various meta-analysis that have looked into the treatment of prophylactic treatment of post-stroke depression, and then it was found out through a Cochrane review of about 63 randomized controlled trials, including over 9,000 participants, that prophylactic uses of SSRI are not really beneficial to the patients. So SSRIs and SNRIs are recommended for depression symptoms and people following stroke when the DSM-5 criteria applies, and that's the standard of care. CBT, for some, according to this paper, received a recommendation strength of level A and TMS of level B. going into the research for how they came to that determination, the efficacy of the CBT on post-stroke depression was due to low-quality studies based on the patient population. And there's also a question of determining, what level of cognitive function these patients have following stroke, and if they're able to have the insight or participate in CBT to benefit from it. And again, neuromodulation techniques such as TMS, lack the high quality as randomized control trials that would give us adequate recommendations. Post-stroke psychosis, a 2018 meta-analysis found prevalence to be around 5%. Average onset about 6 months following a stroke, and delusional disorders were the most common. And this was an interesting meta-analysis, and I was going to actually maybe present this paper first, but there were some problems with the paper that I thought this would be a better one to talk about. But in this meta-analysis, it was very thoroughly researched. It was only researched in Australia and New Zealand, but what they had done was looked at studies, all sorts of studies, from randomized control trials to reviews to case series and case reports, and came up with about 2,440 articles. And after going through their exclusion criteria, only about 76 studies were applicable to kind of extrapolate information from. And that included about 260 patients with post-stroke psychosis. And the delusional themes that were most common were persecutory delusions, delusional jealousy, Othello syndrome, reduplicative paramnesia, and somatic delusion. Delusional jealousy was the most common, and symptoms such as negative and positive symptoms of schizophrenia were really rare. And so detailed randomized controlled trials on management of post-stroke psychosis are lacking. Same principle of treatment as those for primary psychotic disorders. Second generation antipsychotics were the most commonly used, and they got a category D strength of recommendation. For acute agitation, Haldol and olanzapine was effective, and that got a category of standard of care. One study did find some benefit of art therapy for negative symptoms for patients that did have them. Post-stroke anxiety disorders, prevalence estimated to be around 20%, and all sorts of anxiety disorders can develop following stroke, including social anxiety, panic disorder, agoraphobia, generalized anxiety, and they're thought to be due to sensory impairment, ICU admission, painful physical conditions, communication difficulties, and sleep disturbances. It should be noted that there is like a significant overlap of patients following stroke that have anxiety, depression, and PTSD. And naturally, we know these people to be having a lower functional status, worse quality of life, and less likely to return to work. Recommendations for treatment of post-stroke anxiety when they meet criteria such as similar to depression, SSRIs, SNRIs, and TCS can be used. Of both category S and category D, and non-pharmacological management, for example, yoga, tai chi, self-help, mindfulness, relaxation techniques do offer some benefits, category C. Here's another Rebus puzzle. Nice little break between the topics. Give you guys about 5 seconds to look at that and see if you can come up with, I think this is an easy one. So it's a hippocampus US, hippocampus. Post-stroke, post-traumatic stress disorder. In some studies, prevalence was reported up to be 40%. Recent meta-analysis, I believe in 2019, found the prevalence to be around 23%. It's related to the psychological trauma of stroke, the dramatic, loss of function, dysregulation of the neuroendocrine function, as well as the structural lesions. We know that the hypothalamic pituitary axis responsible for cortisol secretion plays a role, and that was particularly closely examined in one of the papers that they presented. And of course, their criteria for diagnosis remains the same, such as symptomatic cluster of intrusion avoidance, negative alterations in cognition and mood, and alterations in arousal or reactivity. Post-stroke treatment recommendations, SSRIs, SNRIs, TCAs, when indicated, antipsychotics, anticonvulsants, and anxiolytics, and non-pharmacological based treatments such as trauma-focused CBT and exposure therapy. And I know it's interesting, I found throughout this article that the treatment recommendations for CBT, the strength of recommendations for CBT kind of vary between depression, anxiety, PTSD. One would think that they would all be the same. And the only thing I could think of is that different patients have different functional statuses that they're referring to here. Post-stroke mania, the prevalence pretty low, less than 2%. Most literature that presents on it is in a form of case reports or case series. They report anywhere from 1 day to 24 months following strokes, and lesions are largely right-sided lesions in the caudate, parietal, temporal, and frontal lobes, as well as the thalamus. Treatment recommendations, same as if it was an acute manic episode. Mood stabilizers are more preferred due to the anti-seizure activity that was more helpful in patients with structural lesions. Post-stroke emotional lability, it's known by various names. Prevalence is about 8 to 32%. Call it pathological laughter, crying, emotional incontinence, hyperemotionality, pseudobulbar affect. Symptoms can be dramatic but transient. And if they're long lasting, it leads to distress, depression, social isolation, feelings of embarrassment, all the reasons to try to treat it. Recommendations for treating emotional lability, again, meaningful recommendations are lacking for that. Some studies did find that SSRIs and TCAs can be helpful, but the evidence for that is lacking. One reason I think this medicine, Nuedexta, which is dextromethorphan, hydrobromide, and quinidine combination, which was recently approved, I think, I'm not sure exactly when, I know it was a few years back, by the FDA for pseudobulbar affect can be used. And I don't think that it was included in this paper just because I think it's the Indian Journal and that medicine might not be available there. But that's one thing that I included by my own research there. Oh, another read this puzzle. We have, this one's a little bit harder. So I think that's a limbic. And I like that they use the cyst limbic system. These are always fun to do. Post-stroke fatigue, prevalence anywhere between 25 to 85%. There's no uniform definition of it. Most commonly, it's described as like a subjective lack of mental and physical energy, which interferes with your day-to-day activities. It's also associated with lots of other chronic medical conditions, including old age. And, these include like diabetes, neurological deficits, heart failure, kidney disease, anxiety, depression, sleep disturbances, and cognitive impairment. There's varied recommendations. Modafinil, mood elevator or mood awakener, I guess, has been found to be useful in some studies, I guess because of its effect on the reticular activating system. Vitamin B12, B1, and coenzyme Q10 has some benefit. And actually the American Health Association and American Stroke Association and the American Heart Associations give category D and S to regular physical exercise for help with post-stroke fatigue and otherwise generalized fatigue. Post-stroke apathy, its prevalence of about 35%, kind of described as a lack of goal-directed behavior with diminished cognition and emotional appetite. It can be mistaken for symptoms of depression. I do believe there was a recent proposed diagnostic criteria for post-stroke apathy, which included like diminished motivation for 4 weeks or more, and 2 of the other symptoms, such as reduced goal-directed cognitive activity, goal-directed behaviors or emotions, and obviously functional impairment to meet that diagnosis. Now, recommendations for post-stroke apathy, acetylcholinesterase inhibitors, donepezil, got category C. Some evidence that was largely anecdotal from case reports include some benefit from amitriptyline, modafinil again, methylphenidate, ropinirole, and Ambien, zolpidem. And I think lastly, post-stroke personality disorders. Most common reported symptom was irritability, which had a prevalence ranging from 12 to 53%. I know pretty wide, depending on which studies you look at, and disinhibition ranging from 6 to 76%, as well as general exacerbation of pre-existing personality traits. Personality disorders were most commonly seen in frontal lobe lesions. Also, I think the wide variability in prevalence was somewhat due to the setting in which the study was conducted, the population that was chosen, the type of stroke, and instruments that were used to kind of assess personality changes. And then recommendations for treatment of that is there's not much evidence for treatment that differs from people that have had stroke than from people with not having a stroke. Evidence suggests the use of SSRIs, lithium, and beta blockers. So conclusion, large randomized controlled trials for neuropsychiatric complications of stroke are lacking. So much of the recommendations are extrapolated for treatment of primary psychiatric disorders. Treatment may often need to be individualized due to the nature of neuronal injury for the patients. Physicians should be mindful of the drug-to-drug interactions, as well as the pharmacokinetics and pharmacodynamics of an aging population. We should also keep in mind that this patient population does present with severe physical disabilities at time, and the neuropsychiatric complaints can be overshadowed by them, but addressing them and keeping that in mind that the prevalence of them is larger than the general population can improve the overall outcome for these patients to a considerable extent. And I think that's all the information I have for you today. Whatever questions you have, I'd be happy to answer or try to answer. Thank you, everybody.
Thank you so much, Syed. I'm trying to bring some people in as panelists. Dr. Lipman, are you here? If anyone has any questions in the meantime, you guys can put them in the chat. What got you interested in this topic, Syed?
So I do want to, thanks for asking. Is that Ariel?
Yes, it is.
Okay. Yeah, thanks
Still
for
trying
asking.
to bring some panelists in.
So I've always been interested in geriatric psychiatry, and I always found neuropsychiatric complaints following stroke to be really interesting because we always I think sometimes there's a a habit of writing off some patients that do end up with psychiatric complaints following stroke and saying, oh, this is a neurological issue, it's not a psychiatric issue. Really, it's both. And as psychiatrists actually have the ability to make those patients feel better. And we know from research that, treatment works and they can improve the quality of life. And so this kind of ended up working out for me this month too, is because I was covering the Peace Geriatric Unit, and we have quite a few patients there who don't have any psychiatric history and who have, pretty interesting findings on imaging that have now have, emotional lability, depression, anxiety, suicidality, general delusional symptoms that respond well. So it was a good sort of kickstart to outpatient for me.
Syed, I just want to comment on your use of the term emotional incontinence. That was pretty great. I like that.
Oh yeah, thank you.
What's the difference between that and pseudobulbar affect? Did you get a sense of the description of both of those? And
so I think difference between emotional incontinence and pseudobulbar affect is pseudobulbar affect is going to be very dramatic. It's going to be largely there 1 minute and not there the next, whereas emotional incontinence can vary throughout the day and I suppose be ever present rather than coming in without any warning. That's the impression I got from some of the reading that I did about that. And I'm sure the difference in presentation may relate to the location of neuronal injury as well.
So Dr. Casey just put in the chat, the difference between pseudobulbar affect and emotional incontinence is the affect displayed is different from the emotion experienced. In pseudobulbar affect, I would assume. Thank you, Dr. Casey, for clarifying.
I see a question here from Dr. Suleiman about ADD in patients with history of TBI. That's really interesting. I didn't run across this in my research, but that's something I would have to look into. I know that the post-stroke fatigue and again, even post-stroke depression can have symptoms of concentration difficulties, which, may entirely be ADD as well. And
something I was curious about too is, of course, when you talk to people who've had strokes, they do have PTSD related symptoms. How much do you think is related to the anatomical damage that they've sustained, and how much do you think is related to the process of having the stroke and hospitalization?
That's a really good question. When I read that it can be high as 40%, that's the question I had as well. And obviously similar to cardiac arrest or other dramatic or asthma exacerbation, those things which can also cause PTSD. You would imagine if somebody had a dramatic loss of function, from their baseline when having a large infarct, that they would develop these PTSD symptoms. But looking into further, the research does show that lesion locations in patients with stroke were postulated to have some effect on the development of mood disorders too. It's possible that the site of bleeding might affect post-stroke development. I know in some studies, lesions in the amygdala or the ventromedial prefrontal cortex resulted actually in reduction of post-stroke symptoms rather than conferring an increased risk. So that kind of indicates that if those parts weren't damaged, you would probably have more PTSD type symptoms. And I don't quite remember it, but yeah, I do believe that the lesion locations have a large role into it as well. It's multifactorial, I think for sure.
Thank you for clarifying that. Of course, it's super complicated. Just going through the chat, Dr. Casey added, because there had been a question about ADHD before. ADHD is supposedly neurodevelopmental and would be a different entity then attentional issue as a consequence of brain injury, but the treatments would overlap. Dr. Suleiman responded, agree, when we see veterans usually join military at a very young age and with a history of being with a TBI and being out of a very structured environment, there's a huge overlap. So thank you for those comments.
Yeah, very helpful.
Does anyone else have any more questions? And Syed, is there anything else that you wanted to add?
No, just thank you everybody for coming to the presentation. It's our last journal club of the year. I think we have one more M&M next week. Thank you, everybody.
Yep, that's correct. We've got RAC coming up after this, and we'll mention it at the RAC meeting as well, but for any residents who are in attendance right now, there is a stress and fatigue session that is mandatory for all residents tomorrow from 11:45 to 1. And I believe that's in the, I'm sorry, did someone say something? Maybe that was just feedback. And that is in the B building in B102, the lecture hall on the first floor. So I'll send a message out about that, and we'll also mention it in RAC. All right, thank you so much. Certainly appreciate it. You guys have a good one.